Thank you very much, Art, and thank you for this introduction about what is really a problem of interaction between the patient, his response, and the ventilator, which is adjusted and set by the clinician. A schematic way to see mechanical ventilation opposed to spontaneous breathing is to say this is the extreme where the ventilator is doing nothing and all the work is done by the patient, and this is the other extreme of total support where there is no muscular activity and only patient's work of breathing. And in between, these are the modes of partial ventilatory support. It's important to keep in mind that with almost any mode of ventilation, you can really go from there to there. The way the patient is working depends on the mode you have chosen, but much more on the way this mode is set on the one hand, and on the specific ventilatory demand of the patient on the other hand. For some modes of ventilation, things look simple, saying that if you change the level of ventilation, here the level of pressure support, you directly influence patients' work of breathing, patients' oxygen consumption, or transdiaphragmatic pressure. So if you increase pressure support, you decrease it. If you decrease pressure support, you increase it. So the clinician has the ability to do that. However, we will see in more details that very often things are not so simple. If we think about the ventilator, it has been again schematically described as the ventilator cycle is described as having 4 different phases: the initiation, the maintenance of the breath, the end of the breath, and the baseline variable. So this is the trigger variable, this is the limit variable, this is the cycle variable, and this is the baseline variable. It's important to realize that this is the way a ventilator is working, because with any different combination, you come with new modes. If you change a trigger variable, for instance, from a pressure or flow signal to a time signal, you switch from assisted ventilation to what is called controlled ventilation. But for the patient, he may interact with both modes maybe in the same way. The limit variable it's obvious that you change a mode if you go from pressure to flow, but you also change a mode if you change a cycle variable. With exactly the same thing, you change the end inspiration based on the flow, like in pressure support, you switch to time, you go to pressure controlled ventilation. So this is a combination of all variables which make the ventilatory modes. Let's take the first phase of the cycle, triggering. If we think about triggering, we think about the beginning of the breath, and of course the capacity of the ventilator to respond to a small demand of the patient. And in this bench study, for instance, we have tested a number of ventilators, and we grouped the ventilators into the old generation of ventilators, the new generation of ventilators, at least in those years, and those which were mostly designed to deliver non-invasive ventilation. And when we tested, for instance, the trigger time delay on a bench with reproducible effort, we observed that the recent ventilators tended to do better than the old ventilators, and that on average the ventilator designed for delivering non-invasive ventilation were frequently at least as good as the new ventilators. So it seems now that ventilator companies can offer something very sensitive. The question is, how much is that important for the patient? And in this study, for instance, we measured in patients the total amount of effort, the pressure time product, during two modes of ventilation, pressure support or assist control ventilation. And in each situation, we used either a pressure triggering system or a flow triggering system. And for instance, if you look at pressure support and look at the total amount of effort, we found a significant difference. There was a small advantage for flow triggering, so slightly less effort for the patient. But if you look carefully at which part of the effort was really due to the triggering itself, it's illustrated here. It's only this part. This is the work due to intrinsic PEEP, which I will comment in a moment. This is the work after the triggering, and this is only the small part due to triggering. So there was a small effect, and because there were other benefits of the flow triggering, we observed something significant. But with assist control ventilation, which maybe was not optimally adjusted for the patients, even with this slight difference, we were unable to see a net effect for the patient. So the triggering is, from the ventilator standpoint, is certainly important, but it's not a big matter. And the reason is that there is a huge amount of effort performed before the ventilator can detect any signal coming from the patient. And this is well illustrated here, and it has been shown in many studies. These two dashed lines indicate the time during which the trigger of the ventilator can be activated. Can be because there is a small negative pressure drop or there is a small increase in flow. Before that, the ventilator, even if it's excellent, cannot detect anything. But you see that in terms of esophageal pressure swings, this is coming very late compared to the beginning of the effort, which started here for the patient. So all this phase is before any possible detection of the ventilator based on signal at the airway. So this is the intrinsic PEEP, which necessitates for the patients to make an effort to counterbalance this positive pressure before any detection can occur on the ventilator. In this study, we applied with Jordi Mancebo a level of external PEEP to counterbalance the intrinsic PEEP. In other words, to reduce the difference between the external pressure and the internal pressure. And as many others have shown before, we observed that with a PEEP level of 10 centimeters of water, we markedly reduced the effort done by the patient as indicated by the esophageal pressure swings. The problem with adjusting external PEEP in patients with COPD is that it may have many deleterious effects, and especially increasing hyperinflation. So in this study, we tried to see whether some simple external index could help us to titrate positive and expiratory pressure, and we used the airway occlusion pressure, which is the drop in airway pressure during the small phase of triggering and related to 100 milliseconds. And indeed, we found that when PEEP was increased from 0 to 5, the external PEEP was increased, the work of breathing significantly decreased, but when it was further increased from PEEP 5 to PEEP 10, there was no significant reduction. And the same occurred with occlusion pressure. There was a significant drop when going from 0 to 5, but no change from 5 to 10. So suggesting that it could help the clinician at the bedside to titrate this important parameter to reduce patients' work of breathing. The second phase of the cycle is, of course, very important, and there are many aspects which could be discussed. I started my talk by saying it's very schematic to think that you have control modes of ventilation and partial modes. This is an example of a classical paper by Michael Ward from Montreal a number of years ago, where he compared the pressure time curve of a patient during controlled ventilation when the patient was fully relaxed and during assisted ventilation when the patient was triggering. And if you compare this curve to this one, you see that there is clearly a major difference, a decrease in pressure during insufflation. And this is easy to understand because during this mode, the flow is kept constant, so during the phase the ventilator is insufflating, if the patient is pulling, trying to get air, the pressure at the airway will decrease. And if you superimpose the two curves, you see that this difference is related to the work, the effort done by the patient. Interestingly, when they made recordings in patients, this occurred also in patients who were supposed to be under controlled mechanical ventilation with no supposed effort to trigger the ventilator. In fact, the patients were doing efforts. And in this study, he found one thing we know very well now is that the peak flow setting is extremely important to modulate the effort of the patient. If you have a low peak flow rate, you will have a large effort required from the patient. This was true for assisted ventilation. This was also true for what was supposed to be controlled mechanical ventilation. The shape of the flow curve may be also important. In this study, we tried to compare the same tidal volume delivered either with a square flow, and this is the flow inspiration is at the bottom. You see here a square flow. It's a classical flow controlled, assist controlled ventilation, or with a decelerating flow like during assist pressure controlled ventilation. In the two situations, the inspiratory time was the same, the tidal volume was the same, so the VTTI, the mean flow, was the same. The difference was the peak flow, which was higher here than here. And just varying the peak flow for the same mean inspiratory flow, you see that the work, the pressure generated by the diaphragm of the patients was markedly different between the two situations, much higher work of breathing during this situation. So the good response in this case is either to switch to a decelerating flow rate or to simply increase the peak flow rate, keeping a square wave of ventilation. But if you do that, if you change the inspiratory flow for the same tidal volume, you also change the inspiratory time. And then comes another interaction with the patient, which is not only the beginning of inspiration, but also the end of inspiration. And this is just a funny example to illustrate a problem we had in our ICU. For instance, this is a tracing of pressure, this is a tracing of flow. If you look at flow, you recognize a very classical assist-controlled ventilation with square flow, an inspiratory pause, and then expiration. And you see on the airway pressure that really the patient does not look comfortable. It's very different from a very regular increase in the airway pressure wave shape. And we found that this patient was ventilated with a low peak flow of 30 liters per minute, whereas the standard should be more around 60 liters per minute. We also found that maybe tidal volume was a little bit low, so we increased tidal volume, and we also increased flow to 60 liters per minute. And you see the flow has been increased, and the inspiration, it's a much more regular shape here, but only during insufflation. And what we discovered was that with this ventilator, when changing the flow, we kept the I/E ratio constant, which means that the ventilator was increasing the post-insufflation inspiratory time, which is supposed to be a plateau. And what you see here is clearly the patient trying to fight against the ventilator because he wants to stop the breath, whereas the ventilator tried to impose a pause at the end of inspiration. So the problem of this synchronization between the duration of patient's inspiration and ventilator insufflation or inspiratory time is also very important. And in this case, the flow setting was not the problem, but the plateau was a big problem for the patient. This is another example where you see a big difference between what the ventilator is delivering, and you see here the beginning of the breath and the end of the insufflation, and you see that it is different from the end of inspiratory effort of the patient. That's why you see this weird curve on the airway pressure. The patient wants more inspiration, more inspiratory time than delivered by the ventilator based on flow cycling criteria. We have discussed over the last years about decreasing work of breathing. Maybe for this reason, people did not pay enough attention to the fact that it's also a bad thing to decrease too much work of breathing. We need to avoid excessive level of work of breathing and oxygen cost of breathing, but we don't want patients to have almost nothing like work of breathing. And I think this is today one of probably the major problems we have in the intensive care. This is an example, again, to show that it can happen even with a mode you think it's very simple to use, like pressure support. You see the diaphragmatic EMG and you see the airway pressure tracing. It looks very nice, very regular. However, if you look carefully at every small EMG activity, this corresponds to very small transdiaphragmatic pressure activity. And compared to the breath, it's only to trigger the ventilator. All the insufflation time is in fact passive insufflation. The patient is doing nothing, just triggering. So there is a total loss of synchrony between what the patient is doing and the insufflation of the ventilator. What can be the problem? Well, two kinds of problems very well described. One is the occurrence of apnea. You see patients who are not breathing for 10, 15, 30, 45 seconds, and usually you have alarm on the ventilator. And this has been shown to be a big problem at night during sleep because it can wake up the patient, at least interrupt sleep. And this may be very frequently a cause of sleep disruption in the ICU. The other problem, you see the small efforts, the other problems, which I will not describe in detail, but again well known, are ineffective efforts, where the patient is hyperinflated by the breath and try to trigger the ventilator without success. Usually, when you see these typical tracings of flow or pressure indicated ineffective efforts, typically the best response is to decrease the amount of assistance. This is just to indicate that it's not specific to any mode. It is described here with assist control, pressure support, or SIMV. Third phase of the cycle is also important, but I will not discuss in detail. But for instance, with pressure support, you know that you can change the flow threshold at which the ventilator cycle to expiration. In some patients, it can really matter. For instance, patients with COPD who have very long time constant, if you have a very late end of inspiration, you can observe these ineffective efforts and change it simply by changing this flow criteria. My three last slides are about a study which will be presented this afternoon by Arnaud Thiel from our group, who tried to address the question of the prevalence of this problem of asynchrony in the ICU. And it was found that in a group of 62 consecutive patients, that a number of patients had a very high number of ineffective effort. This is an index quantifying the number of ineffective efforts. And one of the main factors was the presence of COPD. In half of the COPD, these ineffective efforts were present for more than 10% of the breaths. If you look at these problems of asynchrony in patients with pressure support, what is important is to see that it was significantly associated with higher level of pressure support, higher level of volume, and not shown on this slide, a higher level of pH, indicating that it seems to be really the clinician who gives too much pressure support to the patient, causing this problem. And the last issue is that when we compared patients with high asynchrony index to patients with low asynchrony index, we found that they had a higher duration of mechanical ventilation, higher rate of tracheostomy, and higher number of patients who remain on mechanical ventilation for more than 7 days. Whether this is a cause of consequence is not known, but it raises the question that if we can do better at synchronizing the ventilator cycles to the patient's demand, maybe we can also improve the outcome of these patients. Thank you very much.
We have time for a couple of questions. Maybe I'll start, Laurent. Thank you for a very good summary of this topic. This last slide I find quite interesting, and I know it would be only speculation, but could you speculate whether, in fact, this is cause or effect? Because clearly, if it's cause, it's quite important for us to try and manage this. If it's just an indicator of more severe patients, so what? So I wonder if you could speculate on that.
Yeah, that's, of course, a very important question, and that's why the preceding slide we clearly saw that, as we expected, that patients who had these ineffective efforts had higher level of pressure support, higher tidal volume. And we said, but maybe it's because they need more pressure support, their mechanics are poorer. And it was not the case. Mechanics were the same, but PCO2 was lower, pH was alkalotic, really suggesting that there is a problem of setting the ventilator correctly. Maybe we don't have all the information, and maybe when you decrease pressure support in these patients, they became tachypneic, agitated, and it was more difficult. I have not the answer. But at least this suggests that this is partially a iatrogenic phenomenon. So we can do something. Whether it will change the outcome, I don't know, but it's I think, worth to raise a question.
You had more patients in the asynchronous index with COPD. So when you separated out type of lung disease, did that make a difference?
No, because COPD was, it also happened in very other different kind of patients.
Did you find a correlation with the level of intrinsic PEEP in the missed effort phenomenon?
We did not measure it. The point was really to have the prevalence of this phenomenon. So in every consecutive patient, every day, without changing anything, we recorded 30 minutes of ventilation. So we didn't want to change anything. The level of intrinsic PEEP would have been interesting. It will be the matter of a second study to try to clearly physiologically describe these patients and see what can be done and if it's possible to do differently individually.
There are no more questions.